could you tell us about the trial design that you're conducting and the endpoints that you're looking at?
Yes, so we actually have a pilot trial that is ongoing. This pilot trial was designed like back in 2023 before EV Pembro became available. So it has two cohorts. One is a cohort which is EV monotherapy, which is what we had originally intended to enroll patients onto. And in
Mm-hmm.
that EV monotherapy arm, we start off patients by dosing EV 3 weeks on, 1 week off kind of a schedule.
Mm-hmm.
And if patients respond well to that treatment, meaning if they have a CR, PR, or stable disease, then we start cutting back on the frequency of dosing. So it would go down to every other week EV. And then after that, if patients in their next scan, if they continue to have a CR, PR, or stable disease, then they go down to EV once every 3 weeks and so on. And then we also have a EV plus pembrolizumab arm, which has now become the main cohort because we tend to use EV more in combination with pembro. And so far we've enrolled 44 out of 61 planned patients in that pilot trial. And in this pilot trial, patients receive an induction course of EV and pembrolizumab for 6 cycles. And patients who have a CR or PR have an option of either dropping EV completely or reducing the frequency of dosing of EV and going on to EV once every 3 weeks with pembro. And in this trial, the primary endpoint is 18th-month progression-free survival, which we are using the landmark data from EV302 as our benchmark. Yeah.
That's very exciting. And I think that will, knowing the toxicities of this regimen, be a very impactful study when we have some of these results. And,
Yes.
in the real world, based on the information that we have now, when you do think about de-escalation or a treatment break, do you stop both therapies? Are there any particular factors that influence your decision as far as offering a treatment break?
Yes. So definitely, patients who have a deep partial response or complete response, based on our experience in this ongoing pilot trial, we are finding that patients who have, a complete response, definitely, but also in patients who have a deep PR, those patients tend to do quite well after dropping EV, after having received about 6 cycles of EV with pembrolizumab. Most of these patients, if they were going to have an immune-related side effect, we end up knowing that. And so most of the times we are seeing situations where they get 6 cycles of EV pembro, and then after 6 cycles we drop EV and just continue pembro by itself. And we have data from EV302. There was recently analysis presented by Dr. Gupta where she showed specifically in patients who had a complete response. About 74% of the patients maintained CR at 2 years. So I think that is definitely impressive in patients who have CR. Our experience in general has been that in patients who just have a PR, meaning they're not really attaining a very great response, like maybe just barely 30% shrinkage of the tumor. Those patients, I'm finding that they're not necessarily sustaining that response after stopping EV. So those may not be the right patients to de-escalate for. And then I also think that patients who have lung disease, like small metastases, like small lung metastases or lymph nodes, they do tend to have a higher chance of attaining that CR and then going off of therapy. But on the other hand, I would not say that one should not offer this type of a de-escalation strategy to a patient with liver metastases, because we do have a few patients on the study who have liver metastases who have also attained a CR and gone off the treatment.
Wow.
One of the things that I in my practice I have seen is that patients who have they are intact tumors, bladder or urothelial intact tumors that they've not had a chance to undergo cystectomy or nephroureterectomy. I sometimes find that they don't maintain long-term CRs. And I think that this is all just very exploratory that I'm sharing with you.
Right.
But I think further studies need to be done where we see if patients who have the intact bladder do they tend to develop resistance to EV faster, or maybe those are different clones compared to the metastatic sites.
Right. That's very interesting. Are there any cases where, as of right now, you are doing consolidative therapy to the primary for patients that achieve a CR?
That's a very open question. We always bring those cases into our disciplinary tumor boards because, one could argue either way. Uh, a lot of times the patient's goals really play into a factor there.
Right.
So if we have a young patient who is hoping to be cured, and they have a CR, then they do take a chance of undergoing a cystectomy.
Right.
Whereas if it's a patient whose initial goal was to minimize treatment anyway, they may just kind of want to stay on Pembro maintenance or something like that.
Right. No, that's definitely still an unanswered question right now in the landscape.